I'm going to record this for the people that aren't here so that we have kind of clear communication here. All right, so what do we have? This is kind of a QI project that I was working on because I got a lot of feedback from residents who were frustrated and nurses who were frustrated. And so I was like, let's try to find a solution that could hopefully help. So the problem that we had were you guys were talking about having a lot of volume of pages, lack of standard communication, lack of clinical context with your pages, and a lot of people seem to be having what I term pager fatigue. And then the nursing staff was like, we don't get timely responses, we're unsure what the responsibility of each of the residents are, and we're unsure what's appropriate to page for. So these are kind of the two main problems that people were reporting. So our current system is that we get a numeric page like 2233, and then we have to call them back, and we have no idea what they're paging us for. We have no clinical context, and then there's no room for us to be able to triage our tasks. You know, when we get 4 or 5 pages in a row, if you're float or if you're a long call team that's getting admissions and you have patients that need help, and the nurse is paging you over and over again, trying to get a response, you might not know what they're responding for, and so that's led to frustration. So what we're trying to do is we're trying to create a new standard system of communication that's alphanumeric. So you'll still get the station number that you're going to have to respond to, but you'll also get a short message associated with that page. We're creating a protocol, or we've created a protocol actually, and I'm going to go through that. And this is kind of for us to know how quickly a nurse is going to want us to respond to them by. And the goal for this is really to improve the communication and hopefully satisfaction as well. So here's the protocol. This is probably the most important slide. There's 4 levels of a page: level 1, 2, 3, or 4. Level 1 is a stat page. Essentially, that's going to be a page that's going to be paged to us, but also called overhead at the same time. That's a rapid response code blue, not a code gray, unless it's a floor patient and they're having trouble getting in touch with the primary team, but potentially a code gray as well. So level 2 is an urgent page. That's where the nurses, yeah.
Level 1 will contain the bed number.
Yes,
right?
I'll get into that.
Okay, great.
Hush. No, just kidding. Level 2 is an urgent page. So that's a response within 15 minutes. That's an expected response from the resident within 15 minutes. And I'll get into what a response means. That's for if you have a deteriorating patient. This is maybe you're having situations that are leading up to a code gray and you're trying to get someone to come quickly to evaluate and hopefully prevent a code gray. Or other dynamic changes that are happening. Again, for us, if you get a level 2 page, the expected response time is within 15 minutes, pretty short turnaround. Level 3 is a routine page. That's still requiring a response, but within an hour. So that's if you have a non-urgent diet order or a PRN question or clarification of an order, something like that doesn't really require an urgent response. Like you're sitting in new conference, you can just wait until afternoon conference to respond to that. And then level 4 is just an FYI page where they don't expect a response. So this is something like, oh, patient was discharged, or I gave this patient, this PRN, and I just wanted you to know. And you don't have to respond to that information. There's no actionable follow-up that's being asked. And then I've written down here at the bottom what Gabe was talking about. Rapid responses and code blues, they're going to be paged to everyone. And in that page, you'll have the room number and the patient's initial. So that way, at least we know what's involved with that situation. So the other piece of this, so the level of urgency is one thing. The other piece is the short message that you'll get for clinical context. The nurses are being educated right now on SBAR, which we also, I think Marge sent a text out about as well for us for consulting specialties. This is going to be for them to kind of consult us, I guess, with a message. And so situation, background, assessment, recommendation. For the nurses, they need to tell us what's happening, what's the clinical context, what's their concern, and then what they need from us. And that's basically what we're asking them to put in their message. An example, so you guys can understand what to expect, is you might get a page that says L2. L2 means level 2. JB, that's the initial of the patient, room number 305, has a temp of 101.8, admitted for cellulitis on cefazolin, vital stable, erythema worsening. Please assess patient, consider antibiotic change, John at 2233. So now you have clinical context, you have a level of urgency, expected response within 15 minutes, L2, 15 minutes. And then now you know which patient they're talking about and what they're asking about. So for us to be able to do this, so you know how some of us have our pages attached to our phones? For this to be kosher in terms of the initials and the room number, our phones need to have a pass lock or biometric scan, like Face ID, to get into your phone. If your phone is unprotected, you can't link your pager in your phone. This is kind of a loophole that we have, but you have to make sure you have a passcode on your phone. Otherwise, we're going to be violating HIPAA and some other things, and we could get in legal trouble. If you don't want to have your phone unlocked, then you can't link your pager in your phone. You have to have a separate pager with you at all times. All right, what happens if no one responds? So the nurses are going to be told, page the first time with the level of urgency with the expected response time. If you don't get a response within that time frame, you can page again with the same, or if it's a dynamic situation, a new level of urgency. So we basically get one strike. If we don't respond after 2 pages, they're going to escalate to their supervisor and or the chief resident. Okay? They might reach out to the second or third year resident that's on the team, or they might just skip that depending on how urgent the situation is and they need to get in touch with someone. They might just skip to calling on overhead as well. So the idea here isn't really to reduce the volume of pages that we get, but give us the ability to triage our tasks. Because you might now get a lot of FYI pages, but that's information that we should know. And honestly, it's a multidisciplinary field, medicine. We need to be talking to our nurses. We need to be talking to these other folks. So the idea is not to shrink the number of pages you get, but at least allow you to triage your pages so that you can address things appropriately. So we talked about the nurses kind of buy into this system. They need to take the extra time to make an SBAR message. They need to sign up for Amion. They have to do a few different steps. This is all working through Amion. So they're doing that right now. What's the buy-in for us? Really, it's to respond in the time, like the protocol time labeled with the level of urgency in a good manner for that. Like that's going to be our biggest buy into this system. Because a lot of times, we'll get multiple pages in the past system and we wouldn't respond, or we would think it's the same thing, same person paging about the same thing. But now we have context, we know what they're paging about, and if it's an L2, respond within 15 minutes. If it's an L3, respond within an hour. That's got to be our buy-in. We're doing the least in terms of the change in this system. So let's help our nurses out by responding to them when they're requesting for a certain time period. Now, they might have a routine request that might require a slightly faster response, like say they need a diet order and the tray is like there. It might be like an urgent page, but it's a diet order, which isn't like an urgent situation. Really, the idea is to respond with the time frame that they're asking us to respond with. So it's less so about what you think the urgency of the matter is, and more so what they need within the time frame that they need it. And then feedback is going to be the second piece of this. I'm showing you guys this so that you guys know what we're doing. I'm sure there's going to be nurses that at the very beginning they might not understand fully how to appropriately triage a task. And so it's going to be a lot of teamwork, us kind of telling them, hey, like that was probably a level 3. I know you made it a level 2 in that moment, and I'm happy to do it. But for the next time, that's a level 3. And that's going to be kind of what the process is going to be, a lot of talking and communicating. But ideally, we hope that this will help like clear up with the volume of pages, like what pages they're about, and also to give us the ability to take time and focus on the urgent things first. What I think this will expand to eventually is including pharmacy, the case managers, PTOT, social worker, etc. If this goes well with the nurses, I think we could expand it to all the disciplines. And then we're also talking with the nurses to create a new committee that specifically talks about our relationship with the nurses and things that we can do to improve it. The idea is it's going to be pretty low impact, like quarterly meetings where we talk about things that have come up and hopefully we can come up with a solution, because right now we don't really have any specific committee dedicated to our relationship with nurses. But I feel like that would be helpful because I know both of us have frustrations on both sides. So we're hoping that that's what comes of this. And then the last piece is you might know that there is an option for a two-way chat on Amion. It's a secure chat. We're trying to avoid that because I think that it's more effective to call someone to communicate with them or see them in person rather than text chat like on Epic or other text messaging systems. But some nurses were asking about that, and they kind of agree. Like they like the idea of talking to you on the phone or talking to you in person because you have more clear communication that way as opposed to a text chat. But it is a feature and something to keep in mind. Maybe down the road we could consider that if we don't get a secure chat in our EMR. But for now, this is the best that we can do with what we have. So I'm not going to go through it now since we're short on time. But if anyone has any questions about how to do it through Amion, you can technically page anyone, ourselves as well. The idea is for nurses not to abuse the system, and so they're getting education right now about what's appropriate to page and what's not. And ideally, this will improve as time goes on. And I appreciate everyone that did the survey too. If you haven't done it, you can still do it, but at this point, we're gonna just put it in place. You might start getting these text messages today or tomorrow, and they're gonna start trying to implement it. They've been already testing it with me, so I know the floor nurses and the CCU nurses are gonna start doing it, so. Any questions, any concerns? Yeah.
How can we make sure they're paging right person, right time?
So that's a challenge. They have our schedule now, so they'll know who's on what shift. The only shift that's difficult that I wish we had more help on for Amion is GMF, where we have 6 teams, and there's nowhere on Amion that says what team is assigned to what patients. We have physician sign out. I'm not keen on giving them access to physician sign out. It's also a headache to do, that many people. So we don't have a great solution for GMF, but ICU and Maxi, they should be able to see who's on and to be able to page the right person. You still might get the occasional, I don't know who's taking care of this patient. We are educating them at looking at the notes from that day. We're educating them at looking at the orders. The one thing we can do to fix that problem is if you take advantage of the update officer order and you put your name, whenever you inherit a patient, you update the officer with your name or the intern's name. Because then I can tell the nurse, just look at that order and you can see who's assigned to the patient. The other thing you can do is write your name on the board. ICU, Maxi, CCU, like it doesn't have to be just GMF. You can write your name on the board for any of the services. They are looking, right now that's what they kind of go based off of. And if there's no name, they might reach out to whoever. So I know interns are pretty good about this, but residents can also go in and put your names on the boards. That will help them too, to figure out who's on what team. Any other questions or concerns?
Will they be able to message the float pager with the same?
That's a good question. I could put the float pager in there. I honestly don't know what the number is, so I have to figure that out. But I can add it in there, and they'll just message the float where the float is.
Is there a limit of, I mean,
Probably
there's,
you have to definitely have it on you.
It's not going to go to your phone, yeah, and it has to be with the battery. What might be easier is for them to know who the float is, and then they can just message to your personal pager. What's your question?
I mean, this is so much great by this.
Mm.
Thank you. But is there, for example, is there like clearly stated differences as to what is so urgent, what is not, like very specific, or else if they want.
We're
like,
emphasizing, we're emphasizing response time as opposed to situational urgency. So what I'm telling the nurses is, what the problem is matters to me less, but when you want a response matters to me more. So you might have a mix of something that might be an hour routine page for one situation that's now an urgent page for another. Like I said about the diet order, someone who might need a diet right away to get their tray, that might become an urgent page, but it's not really an urgent situation. So if it's something that requires less than an hour, like much quicker than an hour, they're just gonna make it an urgent page, but at least you'll have context. Like if you're sitting in noon conference and they urgently page you for a diet order, you just throw the diet order and you don't have to really call them back. But part of the response is to call them and check in with them. So if you don't have to get up and you put the order in and everything's fine, then it's fine and you can call them afterwards. That's okay as well for noon conference. But outside of noon conference, you would want to talk to them or go to the nursing station and address it within that time frame. And I think it's reasonable. Like stat is going to be an overhead, that's immediate. 15 minutes is plenty of time to get your ducks in a row if you're dealing with something. An hour is more than enough time to get your ducks in a row to address something. And then hopefully you'll be getting more FYI pages rather than pages to just tell you something. And then you don't even have to worry about responding in a phone call or visiting the nurse. So, all right, sounds good. Any other questions, concerns? No? All right, you guys can go. GMF can stay.
Thank you so much.
Yeah.
Starts tomorrow. Congratulations, starts today. You just started getting pages for it. Nice. Since it's already on 30, we should probably just let you go. Yeah, I think so. Yeah. I mean, because normally we roll right into it at 1 o'clock and we try to end at 1:30. But I'm sure they've got things to do.
That's fair. All right, GMF can go.
As you can tell, we're going to have to add this to our inpatient service guidelines.
Yeah.
Yeah. I added that to my Notion. I'm using Notion. Have you heard of Notion?
No, what is that? Oh, is that?
Task app.
Oh, okay.
Yeah.